first off, I just wanted to say thank you, and I can't tell you how much I appreciate and we appreciate the partnership that we have now, because it is helping us really stay focused and understand many of the things that you have sorted through here at the Harry on how to engage the community and how to help the community. Certainly getting things to the community. And one of the reasons I've been dean now at the UK College of Medicine for about 3 years, a little more than 3 years. I came from the Northeast, but came here to really serve underserved populations. And I think in our region and in your region, as well as throughout the U.S., there are many needs in terms of many areas, many medical needs, and obviously addiction or substance use disorder is really critical. I have a quote by Gandhi that basically says, "The best way to find yourself is to lose yourself in the service of others." And I think that's what we're all here trying to do. The question is how do we do that best, and how do we share what we know and what we've learned with each other so that we can do a better job. And one of the concepts at the College of Medicine that we've really embraced is that multidisciplinary team-like approach, because we all don't know the answers. In fact, what I'm going to share with you really has little to do with my own answers, but really a lot to do with the full team. I want to thank Dr. Dean Veronica Mallett. I want to thank Dr. Pat Matthews Juarez. I want to thank, who's just up here, Dr. Paul Juarez, and I want to thank Dr. Catherine Brown for the invitation. And I just want to say that our team is excited to be here. And I can tell you, if you hold the fourth annual meeting, I suspect we're going to have even more from the University of Kentucky, if we're invited again. See, all right. But you already heard, from some of the members, and Dr. Scotty Day, who's head of pediatrics, and many of the programs that deal with opioid use and related, Dr. Roberto Cardarelli, who's head of our family medicine, Dr. Janet Osorio, and Dr. Renee Scale. So, some of us will be in and out, and I'm going to have to head back to some of my duties up in Kentucky, University of Kentucky, along with Scotty, but we are glad to be here. I wanted to maybe just go over and take a lot of time in the introduction, so I apologize. And so there are a few slides that I'll go through that I will skip through rather quickly. But one of the things in the College of Medicine that we paid a lot of attention to is, as I just mentioned, is bringing teams together. We can't all do it alone. We actually call this a transdisciplinary strategy. This was part of the strategic plan that we put together just about 1.5 years to 2 years ago, and it focuses on research and education driving healthcare. So we really try to connect at least the various disciplines that we have. The pillars in the strategic plan, like your pillars, include clinical care, but enriched by research and enriched by education, and how we might use those to even enrich education of our students. These are some of in Kentucky, and I know you have some of the similar concerns where we rank, unfortunately, first in cancer mortality, or you couldn't even say in the top 15th or so in many different areas, including fourth in drug overdose and addiction. This is that concept of a transdisciplinary strategy. I use the term a lot at the college. I can tell you most of the faculty really don't like the word transdisciplinary, but in truth, if you were to ask the question of how can we be more connected and engage on a problem, if you look up those various words of unidisciplinary, multidisciplinary, interdisciplinary, transdisciplinary actually has some meaning. What it really gets at is not everybody just bringing to the table their own area of expertise, but everybody coming to the table to address a problem or a question together with their expertise. So it's really starting with the problem. It brings together people much earlier, and you could imagine a better outcome, a better protocol, a better plan because of that. So we really try very hard to start with the question or the problem and bring together many different disciplines, sometimes disciplines you wouldn't even think about, that relate to perhaps how to engage the community, even though we might discover a drug, or one of our researchers might discover a drug or a new agent that might be a new MAT, a new medical assisted treatment option. The truth of the matter is if you bring it to the table earlier, you might come up with something different, because you may find out at the end it was something not so useful for the community or perhaps the underserved community. So you want expertise of everyone earlier. So we really emphasize this concept of transdisciplinary strategy. So it really means something to us. Just a couple of comments. We try to be very research intensive at the University of Kentucky College of Medicine. But we don't look at research for just research sake. We look at it for its impact. How can we have impact? Well, we do know we need to grow it, but we bring teams of more basic scientists together with clinicians, together with community experts and workers so that we can actually transform. So we look at this whole continuum and we try to rapidly go through it in different ways. These are signature areas in our research domain at the University of Kentucky. In fact, through the strategic plan, we said we can't do everything, but we'll try to do as much as we can, and we'll certainly try to meet the needs of all those in the community that have various health-related issues and other concerns. But we did come up with 5, and then another one we call emerging areas of research that we were going to focus on, and that we've been focused on. Obviously, substance use disorders is key. Cancer, I think you know we have an NCI-designated cancer center. You already heard my background. I actually come from a background of being a director of an NCI-designated comprehensive cancer center. So we tend to try to think in terms of those team approaches programmatically: cardiovascular disease, diabetes and obesity, neuroscience, and many emerging areas. I'm going to say a bit about what we're doing in the one signature area, substance use disorders. The other way we try to think in terms of this continuum is not just the areas, experts in discovery, coming to evidence, how we get evidence into the clinic and community. And actually, I have another slide, and unfortunately I put this one in, that has community on the total right. But not just those areas, but how we catalyze those areas. So you always think of an enzyme reaction. I think most of you, everybody here has had biology, chemistry, and so forth, and you think about one particular chemical or molecule going to another. Well, how does it get there and transform, and how does it get there more rapidly? We catalyze it, so we have enzymes that actually move it through faster. We pay a lot of attention to the areas in between. One area in between we call the kind of translation of more discovery to evidence, and we have programs, one of which we call the Multidisciplinary Value Program. By the way, it should be transdisciplinary multi-value program. I got a lot of criticism at the college because I said transdisciplinary, but MVP rings well at UK with kind of an athletic connotation. TVP wasn't going to work, but it should be TVP. And then the other area, which is very important here, is how do you really get it to the clinic and the community? Implementation. We paid a lot of attention to implementation activities, implementation science, and implementation type efforts. I won't focus on that as much, but what I'll tell you is, and I'm going to just talk about it briefly, the HEAL grant and award that just came to Sharon Walsh and her team at the University of Kentucky is basically a very strong implementation science project to implement evidence-based approaches in prevention, in use in medical therapy for communities, and I'll talk a little bit about that in a moment. If you look at this multidisciplinary value program, kind of a catalyst to move that continuum along, what we decided to do is facilitate it. We decided to actually give substantial grants of investment out of the college to form teams, but we said the teams have to be very specific. They need to get to the table. They need to be able to generate not only discovery, but discovery to the clinic and community in some way or another. And to do that, we would give various awards. We've awarded a whole number of them. We started to change some of the names in different ways. So we did MVP awards. We gave each one of these teams, if they come to the table and generate something that got research into the clinic or community or both, we gave about $110,000 awards. We did the same with what we call Value for Implementation Awards, or VIP. That was more the implementation science. And more recently, we've been doing alliance programs. So this is the way we've approached fueling and investing in much of the research to bring people together programmatically. I'm going to just share with you one of those MVP awards, which relates to opioid use, and obviously something that we're trying to take further. This is an awarded program that's combining opioid addiction treatment with care for those patients that come into the clinical setting or the healthcare setting with medical complications of opioid or substance use disorder. Much of it because it relates to also using IV drugs and infections and so forth. And this was a focus specifically for patients that had endocarditis. And what we noticed is that patients coming into the health system nationally or even in our hospital that had endocarditis related and associated with substance use disorder would often go out of the health system without proper treatment, both on the behavioral end and the medical assisted or the medical end for their addiction. If you actually look at it around the country, the percentages are low. Even in our own hospital, we felt we needed to bring up the percentages. And that's what this program was about. And this program randomized to the NAT with buprenorphine, any antibiotics because they were getting treated for a particular, for endocarditis. Some of them having valve replacement versus a more outpatient approach where again we used buprenorphine but got them out of the hospital and continued counseling, behavioral approaches along with NAT it continued. This is just the beginning group, so it's a small cohort, but it gives you an idea of at least the population that we're talking about. And as I mentioned, many of them with various other infections. I'm going to skip over. Bottom line is even in this small cohort, statistically significant, getting patients out of the hospital, inappropriate treatment with NAT, 100% completed their antibiotics. We had a 23-day reduction in length of stay. This was with 3 weeks, we shortened inpatient stay because they got 3 weeks of outpatient antibiotics for their endocarditis, decreased illicit opioid use, and decreased IV drug use. And we even did urine testing to show that, in fact, they were not back on opioids later. So, fairly successful, small effort. But what did it do? With some small investment, it brought a team together with various expertise. Dr. Laura Fanucchi and Michelle Lockwell are part of the HEAL team, the HEAL team and grant that I mentioned and that Paul mentioned earlier. And they're part of a number of efforts like this, and I'll mention some of the stuff that they're doing in the clinic. So this is just an example of $110,000 award. They're now presenting this in all sorts of forums nationally, grant submitted publications, and even that MVP program where we funded 9 teams. So that's about $1 million. When we calculated in terms of federal dollars that have come in, it's been over $4 to $5 million already. So it not only is an investment that it brings in additional support, but it brought teams together. Okay, and I want to share with you just one of the smaller teams related to opioid addiction and opioid use. This was mentioned before. Paul mentioned a little while ago that Sharon Walsh and her team at the University of Kentucky, that's their team right there in the picture. It's a fairly large team. It's not only Sharon Walsh in the College of Medicine, but it's through multiple colleges. And it's not just a partnership with the University of Kentucky faculty, it's a partnership with the community, with the state, and with the Justice Department, Public Safety Cabinet, et cetera, to really launch something that is essentially implementation science, implementing therapy in the broadest sense, including medical therapy, out in the community. Some of the most difficult rural areas in Kentucky, some of the most underserved areas. It's in 16 counties, and what they're actually doing, in a sense, now she'd give you more details if she was here, but what they're doing is they're setting up sites of staffing in these locations, in these communities throughout Kentucky. So those staff can work on education and work on treatment, and it's the full gamut of everything from prevention, to looking at how to manage overdoses. So essentially using naloxone and so forth, syringe programs, and MAT, and how you get that out in the community. There is a bold goal here of reducing mortality over 3 years by 40%. And I'll show you a slide in a little while in terms of where the data is on MAT, along with behavioral interventions, in terms of a good possibility and likelihood, and I think it's going to likely happen, that we could reduce it in a broad community setting if you have people on site, so they're actually reaching those communities at those communities. So there's been a lot of attention to that. Just to say that we don't focus on numbers for numbers' sake. but we've had a lot of growth in our research efforts in using at least federal awards in terms of grants, not including the HEAL Award, because that's almost $90 million. So not including the HEAL Award, we've been growing with very much a kind of a transdisciplinary approach, bringing people together, helping some of the faculty that are there through a number of different strategies. But even in the last 3 years, we went from federal grant awards of $82 million up to $112 million. And I'm going to skip over this because this is kind of showing ranking or whatever ranks the ranking that we went up. And it's not important for numbers' sake, but what it does reflect is a strong community of research activity, but research activity that's there to make an impact and hit the community in a positive way, so impact in a positive way. In terms of education, I just have a few more minutes. We are looking at a number of programs in education. We did create a white paper. We did that in conjunction with multiple medical schools in Kentucky and dental schools in Kentucky. And we are trying to use this as a guideline as we revamp and work on the curriculum for our medical students and for you know, really, I mean, you know, we're all students one way or another, but opportunities even for our healthcare workers and so forth. We work on kind of the whole concept of core competencies. What kind of core competencies do we want our students to have? I'm going to skip through these slides quickly. I think you have access to them. If not, I would make sure you do. So I'm going to skip through them instead of going through year by year in terms of our medical students. And what I wanted to just get to is the other thing we've been focused on is waiver training. Michelle Loftwell, who's also part of the HEAL grant award team and runs what's called a bridge clinic at our center. I'll tell you about that in a moment. Also runs a waiver program and trains our physicians, our healthcare workers, and we've been more recently, since February, working on training medical students and residents. And you heard about that before mentioned. This is allowing, obviously, for those that are physicians to get a waiver and to get an X license that they can prescribe MAT. But what Michelle has told me, again, I don't want to quote her too much or whatever, so if I get it wrong, I apologize, Michelle. But what she has said in this program is she understands, and they understand, that it may be that those getting training for the waiver program may not actually ever prescribe. In fact, she suspects it's going to be less than 50% prescribed. But what she's seen is, like the MVP program, where for endocarditis, there's a low percentage of patients that go in a healthcare setting, get treated medically, and then go out with proper treatment, MAT and behavioral interventions for addiction, that this is going to help those specialists even feel more comfortable in proper referrals to those that would prescribe MAT and or have behavioral interventions as part of the package. And right now, many of the physicians are not comfortable with at least treating and even identifying these types of patients. And so her feeling is that she's comfortable that many of them, may not actually ever prescribe, but they're going to be more comfortable and have learned something. Now, it is true, there needs to be follow-up. How do you really do it and so forth? And I was talking to a colleague before who's here as part of the program as well. And we were talking about the fact that you do need mentors for these, long-term, for anybody who would go on to perhaps prescribe MAT. These are just the last couple of quick slides. This is just showing at least one large meta-analysis that looked at and showed decreased mortality rates with MAT. This is, in this case, buprenorphine. This study also looked at methadone. And the bottom line is if you take all of these studies together, what they've shown is we believe we can reduce mortality somewhere between 40 and 60%. So there were depending on studies on buprenorphine or methadone, and that's why I believe that at least the setting of the HEAL program was to try to reduce mortality by 40%, which is a big deal and pretty impactful. And coming from an oncologist who has strived, in years to publish, and have various therapies that can reduce cancer mortality, these are big percentages, and this is real impact. And the last thing I'll show you, and really welcome any of you, if you did want to come up to UK to observe is we have launched what we call a first bridge clinic. It is very active right now, and this is to really get people and patients with opioid use disorder on treatment, and we connect with our emergency room, emergency department, and we make sure for hospital discharges so that just like the endocarditis example, the moment somebody's identified, they have a clinic that is specific to try to rapidly take care of those patients and connect them for long-term follow-up and treatment. We also have an inpatient addiction service that was launched this past year that connects with the Bridge Clinic, and we have a program called Pathways and Beyond Birth Clinics that deal with basically integrated medical assisted MAT for pregnant women and certainly parenting mothers with opioid use disorder in a number of ways. This is just a couple of other areas where you could find at least access to where to get waiver training, although there's many of you in the room more expert than I am in terms of opportunities in the region. If you had a question, please contact us. And I just leave you with just a summary of the College of Medicine that we have grown, and we're really trying to do every single component, every single box, paying attention to how we have impact in the community, and certainly growing our students and educating our students to be here to serve. And I'm going to stop at that since I probably have a big time zero at this point. And thank you for the time. Appreciate it.